Sawadika, welcome to the second live streaming interview sessions of day one of this 22nd Bangkok International Symposium on HIV medicine. Once again, I am Patchari Raksa Wong. Now, we are going to go straight into the interviews. We'll be focusing on PrEP. 20 minutes. Ajahn Nitya is here with us. Ajahn Dr. Nitya Panupak, Chief of Search at the Prevention Unit of the Thai Red Cross AIDS Research Center. So once again, we're going to focus on PrEP for the next couple of minutes. 4 topics altogether, and we'll begin with Thailand's road to universal coverage of PrEP. I would like to bring on stage here Professor Taweesap Siraprapasiri, Director of the National AIDS Management Center, Department of Disease Control at the Ministry of Public Health of Thailand. Sawadika. So we're ready to squeeze out more information from you, and we don't have much time as I do believe that you have to rush off, but we do appreciate your presence. So I'll leave it to Dr. Nitya to pose the questions to you.
I think we have been proud as being Thai to be able to say that our country is considering, even though it's like provisional approval of having PrEP under our universal health coverage. And I think we have learned quite a lot from the challenges that Ajahn Taweesap shared with us here today. And I think it would be very useful for other countries to learn how you think that we can frame the condom use concern and STI concern with the rollout or the scale up of PrEP in the countries in a way that it gives the policymakers in the country the comfortable feeling that we are not leaving STI or condom use behind when we are talking about PrEP scale up.
Okay, so as we know that PrEP is effective for HIV prevention, not for STI. When we integrate PrEP into the HIV program, there are a lot of questions or concerns about the resurgence of STI and also whether it will deteriorate the condom programming. However, if we look at this carefully, this is not the problem or challenging or barrier to include PrEP for additional prevention. But it actually the opportunity for us to improve the STI programming and screening, because if we look at that, the problem of STI issue is that this is the co-infection of people who receive the HIV prevention. They have both STI or they might risk for STI and HIV. So actually we have to strengthening to screen them and improve them in to the services. So the HIV program will work closely with the STI and integrated the screening services as well as provide the treatment of STI to all. And the other issue is that PrEP is not to replace the success of condom program. It's the combination, it's the complement for those who are not comfortable or not able to use condom. So this would be the additional tool for them for HIV prevention. So actually this is the good opportunity that we would strengthening the HIV prevention as well as extend the prevention to the STI program, not to make the problems.
Yes, thank you very much. And I believe that by hearing this, many people are still concerning, probably not from the policymaker view, but from the implementers view, that if we are saying that PrEP is always with condom, are we deferring away those who are actually the target population for PrEP by saying that if you are taking PrEP, you will need to use condom as well, but they are not using condom anyway? Will they be not seeing as target or seeing themselves as someone who should come in and access PrEP service that we are now offering for free?
Yeah. Actually, it's not to target only those who do not use condom. Even those who use PrEP will receive the education on condom use. Because when we're talking about the infection when you have unprotected sex, it's not only the HIV but for STI. So actually you might consider this is the double protection that if you use both condom and PrEP, you would be able to protect both. And so it's the way that we have to look at PrEP is not the additional tools for those who are not comfortable to use condom, but it also make benefit to those who already use condom that would make the people double protection, as well as to get more education to be more safer in behaviors.
So I think the last question here would be around how you see the Royal Thai government as the leader in this region in getting PrEP into a tangible action of how it could be seen as a combination HIV prevention package for the country to say something to other countries who are thinking of how they are going to scale up PrEP in their countries.
Our message would be that our experience is on the way, but we are happy to share what we have faced, and we encourage that during this critical part, HIV is during the last mile of ending AIDS. This is the critical point that we have to use effective tools together and to make this access to all, not only to those who are able to reach the services, but there are some people who may left behind. So the role of the government is to ensure that those who need, whether they are in different area, whether they are poor, whether they are stigmatized, they should be able to access to the effectiveness services to prevent and to living in the quality of life.
Thank you very much.
Thank you very much indeed for your precious time.
Thank you.
We are just talking here to Dr. Taweesap Siraprapasiri. He's the Director of National AIDS Management Center here at the Ministry of Public Health of Thailand. Now, what is so key is continuing to scale up PrEP, but at the same time, we cannot push away the traditional methods, and that still needs to be implemented. And also very important is that education remains very, very key to preventing the spread of AIDS, etc. Once again, thank you very much for being here with us on this live streaming program. We will continue to focus on pre-exposure prophylaxis. We're now going to get an overview of PrEP implementation models now. Earlier inside the main plenary session, we heard from Dr. Toshibumi Taniguchi, who is from the Department of Infectious Diseases in Chiba University, or at Chiba University in Japan. Sawadee ka. He joins us now to tell us more.
Yes, absolutely.
Yes, I think that everyone is so envious about how you have traveled to so many places in the world to the clinics who are like demonstrating all these best practice for PrEP implementation. I would like to start by asking you which models, it could be multiple models, do you think that it would really speed up PrEP implementation in countries in our region which are hardly hit by HIV, and for example, the Philippines, the Indonesia, and lastly, like in your own country, which models do you think would be the best way to go?
So during my presentation, I've shown models like from London, San Francisco, Melbourne, which is Western country, and they have lots of resources. Now, I don't think that is applicable to many countries in Asia. Okay? So I like the Thai model, which has a key population-led PrEP. And I think demedicalizing PrEP or HIV testing is a key component for success in PrEP scaling up in Thailand, as well as other countries in Asia. Now, in Japan, we have a different problem. So we have a problem that the policymaker is not really supporting much to scale up PrEP or even initiate PrEP. So at this moment, we're kind of like struggling with that. But the key population that PrEP is very strong. Demedicalizing PrEP is a very key component, I think. So I'm really jealous of you who started the key population-led PrEP.
I think the key word around the demedicalization of PrEP is something that is very interesting. Would you be able to clarify on that point a little bit more on what you see could be potential demedicalizing activities that we could start right away in countries in the region?
Yeah, so I consider HIV prevention very similar to contraception. So giving PrEP is like giving oral contraceptives. So when we talk about contraception, we don't only talk about oral contraceptions, right? I mean, you have various methods: condom, diaphragm, IUDs, and you also have the injections to prevent contraception. So in other words, when we talk about HIV prevention, I think PrEP, like giving out Truvada, is only one method for HIV prevention. So when we talk about demedicalizing PrEP, it basically means that you have to lower the threshold of giving out Truvada. And also, you have to lower the threshold to get the STI and HIV testing. Now, in some countries with rigid regulations, I think prescribing is only allowed to doctors or nurse practitioners and testing only for lab technicians. But I think that threshold should be lowered.
Very interesting indeed here. So we are now focusing on some of the best practices that you shared with us and models that are effective. We really appreciate that. And also during this part of the interview, shining a spotlight on demedicalizing PrEP. Thanks very much to you, Dr. Taniguchi, for sharing some of the ways you think which works in achieving that goal. Thank you. Thank you very much for joining us. Once again, we were just speaking to Dr. Toshibumi Taniguchi from the Department of Infectious Diseases at Chiba University in Japan. We now continue to the next topic, Thai Red Cross experience with PrEP. And we are now going to bring on stage Dr. Reshmie Ramautarsing, Prevention Thai Red Cross AIDS Research Center. Sawadee Dr. Reshmie. Thanks very much for joining us here.
Thank you for having me.
Yes, Reshmie, you have inspired many of us among the audiences today that beyond just having a keyword of key population-led health services, you can actually demonstrate some innovative sub-models of those express service as well as how you collaborate with private sectors in order to try to have as many PrEP outlets as possible in the country. So I would like to hear more from you on when you talk around the express service. What is the rationale behind you started to think about service needs to be expressed?
Okay, that's a great question. Thank you very much. I think in terms of the express, it's a big picture, right, of service delivery. So on the one hand, you see, like I showed, that retention is not optimal. Then we see that community-based clinics are very busy. And we also see that the lay providers have a lot of things to do. And we actually sort of use the idea of differentiated service delivery as well to come up with this express idea where if you can decide that these people don't need that much attention and can go through the service quicker, and they don't need to talk to the counselor every 3 months, for example, then the counselor will have more time for those people who have questions about PrEP, who have not started PrEP yet, thereby facilitating more PrEP uptake. So it's different reasons, and I think that really illustrates the importance of looking at your program from all angles and getting all of that information together to come up with service optimization ideas.
That's very, very nice to hear. And I think many countries may think of like, we have not yet started PrEP implementation. We are not yet ready to talk about too many clients in our clinic.
Right.
We don't need to be expressed at this time. But you also mentioned another like large service gap, which is demand, risk awareness, in which I think you see if we can frame the PrEP as a positive or again framing tool for health, that would really help increase the demand, right? Can you explain a bit more about that, and what would be a practical actions to do so?
Okay. So I think just to add a bit more to what I said, and just to summarize what I said, is that we have loss framing, which is when you really just focus on risk and you rely on people to identify their own risk and then say, oh, I'm at risk, I need PrEP. And that potentially, or actually that leads to people being left out. As I showed, a very large proportion of our clients don't see the need to use PrEP because they don't see themselves at risk. And gain framing is actually a concept that has been proven in HIV, no, not just HIV, in prevention behavioral research, and has showed that it is a more effective way to reach people who are not aware of their risk. And so, like I said, it's not just something that we need to take into account for campaigning, but it should be a unified message that comes from all sides to the clients. So it's something that they see on TV, hear about on the radio. When they go see a doctor, that is something that should be explained to them in that way. And by focusing on health and on positivity and on taking care of yourself, you're much more likely that people will think, oh, that's actually something that I can also do to take care of myself. And the key here really is the consistency across all outlets to have one unified message. And I think the reason that I really wanted to pay attention to this concept is because I feel that in the region, the messaging is not uniform enough. There's lots of hesitancy around providing PrEP among PrEP providers. And I think that could be potentially quite dangerous. So it's very important to get everyone on the same page so that we can have one message for our clients.
Yes, I think that's very important as an entry point or starting point of getting someone to think about PrEP as an option for health promotion.
Yeah.
I feel that this could be, this is very easy to understand, but it could be quite challenging to be accepted, especially when you are talking about PrEP in a health promotion way, because PrEP is kind of always be linked to sex, and how to have sex with the pleasant of having sex may not be something that people in the society would see as like the priority in life or in health. And when we say that right now, if you want to have a pleasant sex, the option for you to have that with safety is to use condom. But if you cannot use condom, now PrEP is also another option for you, or you can use it together, double protection. For you to say this like as a medical doctor,
Yes.
to the society, to someone who may have, who may be parents of adolescent kids at home, to say this to someone who are school teachers. How are you going to frame that? And I know you are from the Netherlands.
Yes. Exactly.
We are in the Asia Pacific. I just want to learn from you, and I think the physicians and especially those physicians who are social influencers in our region may be able to like start thinking outside of the box and then frame how they talk about PrEP in a better way.
Yeah, it's a very good point that you bring up, which is the difference between how we approach things in the Netherlands, right? Where I was trained there, we're very direct, and talking about sex with your kids is the norm. But that didn't happen overnight. It happened over decades, right? Decades really. And I think in the Asia Pacific, it's a even within countries, very different cultural situations. But I think we all need to start to realize that sex is normal. And maybe we are already realizing it, but we don't dare to say it. And we should start normalizing sex, because from working on PrEP in Asia for so many years, I really feel that there is a moralizing component that's hindering the PrEP implementation and scale up. So if we don't address that, if we don't start to talk about sex, normalize sex, and make sure that having pleasurable sex is a priority in your life, or at least something that you pay attention to, then we can have many different models, and we can have NHSO coverage, but it will still be difficult to get people to realize that PrEP is a way to improve your sex life. So I would say start somewhere, start slowly, start, like you actually mentioned yourself, start with influencers, and start just talking to your patients as well about sex. Just ask, are you having sex? Who are you having sex with, and how are you having sex? And is that going well for you? And I think just by asking that as a medical professional, you have a bit of a different role. So you take the lead in that, and you tell people then this is okay for us to talk about.
That's very interesting tips as clinicians or professionals to hear.
Right, very true. I was actually very, very interested in this, and I think it is more difficult to normalize it, if you will, depending on the cultural context of each region, each country, etc. But just further emphasizing what Dr. Reshmie said, a unified message to create a unified positive perspective of PrEP, and also pushing for it to be, say, a normal thing, linking it to health promotion.
Yes.
Those were some of the key words which I picked up from that very, very interesting discussion. Thank you very much for offering ways to normalize it or make it viewed as more of like a positive, in a positive light. Thank you so much, Dr. Reshmie, for joining us. And further talking about PrEP, scaling it up, making it a normal thing. And we'll continue to talk about PrEP. We now have another guest who is going to join us. He's a familiar face. Every year he joins us, and I appreciate his presence and his knowledge, his expertise. Let's bring on Dr. Donn Colby, Senior Clinical Research Physician at SEARCH at the Thai Red Cross AIDS Research Center. Hello, sawadee ka. You're well, I trust?
I'm well.
And
My
busy.
ankle a little less well. I had an
noticed
accident
you
yesterday.
But it's not too bad.
Not too bad.
Okay,
Yeah.
well, speedy recovery.
Thank you.
All right, let's begin now.
Okay.
You always have so much to share.
I'm very happy to share as well.
Yes, Donn touched on two very important aspects which I would say very common concerns for PrEP implementation, which is the potentially increasing rates of sexually transmitted infections and HIV drug resistance with the wider scale up of PrEP. So you mentioned a little bit at the end of the talk how to prevent or how to address these STI concerns and resistance concerns. So I think with the time we have here, I would love you to expand much more, maybe starting with the STI component first, because we talked with Dr. Taweesap on how the Thailand as a country see the integration of PrEP under universal health coverage as a way to re-energize STI services in the country. And I would love to hear from you more.
Okay, yeah, thank you. So one thing I think that's important to note is that with PrEP, we do see increased rates of STIs, but those increased STI rates were actually increasing even before PrEP came out. PrEP's only been around for 5 years or so. So STI rates were increasing for various reasons even before PrEP came out. So, and that increase continues. And is PrEP causing that, or partially causing it, or filling it? We don't know. But we do know that STI rates are high. We also know that people are on PrEP because they have risk for HIV infection, and HIV is an STI. So somebody at risk for HIV is going to be at risk for other STIs as well. So we can expect that our patients who are put on PrEP are going to have high rates of STIs. So we know they have high rates at baseline, and we know as we follow them over time, they have high incidence rates as well. So the question is what can we do about that? So it's a good question, and I think there's some limitations based on resources, on what's sort of possible and what's available. So we have to think kind of what is sort of not only necessary, what is kind of feasible within the resources available. There's kind of the two ends of the spectrum. One is do nothing, which is what a lot of people have been doing up until now, which we know is not enough. And then there's sort of the Western models where you do everything, where resources are not as much of a concern, and they do every test they can, at every opportunity, on every person that they can. So, and it's not an all or nothing. We have to see, within the resources available, what is feasible. So I think specifically talking about maybe public programs that are implementing PrEP, and thinking how can we integrate STI services into the PrEP services as well. So I think you can start with the things that are very simple to implement and don't necessarily need a lot of resources. So for example, would be syphilis testing. So syphilis, we know, is a very common STI, very high rates everywhere that we look at it, particularly in high-risk populations like MSM and transgender women. Syphilis tests now, they're available in rapid tests that can be done on-site at a community-based clinic as well as in a hospital. And they're very inexpensive, maybe 50, 100 baht or something for one test. So that would be the first place to start, to do two tests that are very easy to implement and don't necessarily take a lot of resources. And do those, could be every 3 months or 6 months or a year, whatever seems appropriate. And then add other STI testing onto that as availability.
In terms of message, keeping the message about HIV, PrEP, and STI out, the concern that we are talking about PrEP and STI, which could be addressed by saying that among PrEP users, we will encourage more condom use, so that probably not much worry about STI because people will be using condom as well as PrEP in PrEP program. That's the message. In reality, many people coming into PrEP program has not been using condom very well. They may decrease condom use over time when they are getting more confident with PrEP. How you as a doctor, as a PrEP prescriber, will be saying or explaining this message to policymakers who may want to monitor PrEP use as well as condom use as well as STI incidents over time, and say or hope that we will see increasing condom use with increasing PrEP use and with decreasing STI over time. How are you going to explain this to the policymakers?
Yeah, it's a good question. I think our role as healthcare providers or as physicians, we can't like tell patients what to do. You can't. They're not like your 4-year-old child who you can say this is what you have to do, and they're going to do it. So I think our role as a healthcare provider is to tell people what the risks are, sort of what they can do to help to improve their own health and protect their own health. In the end, though, it's up to the individual to decide, I'm going to do this or not to do this. So I think that what we say is what we do is we give the information to our patients. It can be about PrEP, and they decide whether they want to take it or not. We can tell them what the risks are for sexual behaviors and what sexual behaviors may give less of a risk for STIs, and how condoms can reduce their risk, both for HIV and other STIs as well. In the end, though, it's going to be up to the individuals to make that decision. And condoms are very, very effective. We know they're very effective. So back in the 1980s or 1990s, when we first had HIV in the West and in Thailand, and we didn't have treatment at that time, condom was really the only thing. And they worked. I mean, HIV rates went down dramatically, both in the Western countries, and Thailand has been a very successful story with the 100% condoms campaign, that condoms, in that context can work. Of course, it wasn't 100%. It didn't get us to 100%, right? But it got us, 70 or 80% of the way there. So we can't expect we can never expect one modality, whether it's PrEP or condoms or anything else, is going to get us 100% to where we want to be in terms of protecting people's health. So we have to give people, these are the different options you have, and how do we combine these options for each individual? And some individual, maybe condoms alone, that's all they need to protect against all STIs. Some people maybe only use PrEP to protect against HIV, or some people might use both. But in the end, I think it's an individual decision, and our job as a healthcare provider is to help that person make the best decision for themselves by providing them with the correct information.
Yes, so I hope that we will get to explain this to policymakers again and again to make them realize that it's no one's best skill to convince everyone to use condom all the time. Yes, and before we move to the resistance part, can I ask you to comment a little bit on the STI test and treat? Do you think that with PrEP program, now we pay more attention to STI, we screen more, we treat more rapidly? Do you feel that this could somehow lead us to like the ending or the elimination of certain STIs because of the PrEP program?
Well, I think so, definitely. So I think by test and treat, you mean people may be asymptomatic, not necessarily have so we're testing for STIs in people who don't have symptoms, which is basically how we went for HIV, right? Yes. and we basically decided in order to end HIV and AIDS, we have to do test and treat, because people can have the disease but not have any symptoms or manifestations and not know. And that's definitely true of STIs as well. So yes, definitely in terms of if we want to end STIs, all of them or one at a time, then I think a test and treat approach is definitely going to be necessary. And in some individual populations, I think we do that already. So for example, for pregnant women, right? For pregnant women, because the STI is a risk not only to the mother but to the baby, so we have a test and treat approach, right? Every pregnant woman should be tested for STIs. And I think that's very successful in basically eliminating infant STIs that are passed from the mother to child. So if we want to talk about eliminating STIs in the community among adults, then I think a test and treat approach is going to be necessary.
Okay, thank you very much. So now we may want to touch on the resistance part. You laid out very beautifully how resistance could happen within a PrEP program. And I think that addressed some concerns from mainly infectious disease doctors that with the larger scale PrEP program is, then the larger problem drug resistance will be. So would you like to briefly summarize the places where resistance could happen in PrEP program, and then to give an advice to countries which are going to start PrEP rollout very soon on how they should prevent resistance at those steps.
Oh, sure. So I think the first thing to remember is that the only way to get resistance to HIV is to get HIV first. Right, so by preventing HIV, that is the best way to prevent resistance, is to prevent HIV infections. So we know from surveillance in many countries throughout the world, in most places, resistance to HIV drugs is about 5 to 10%. So 5 to 10% of people who newly get HIV infection, that HIV already has some resistance to drugs. And we have a lot of drugs, so we can always find another drug to treat them with. But if there's millions of people in the world have HIV, then that 5 to 10% is hundreds of thousands or millions of people who have some resistance already out there in the community. So with PrEP, though, it's a little different issue because the person who's starting PrEP, which is an ARV drug, the same drug we use for treatment, they don't have HIV infection, right? So if you don't have HIV, then there's no risk for that resistance developing. But there's a few small scenarios where resistance could happen. So we know that from the time somebody becomes infected with HIV until their HIV antibody test becomes positive can be about 2 to 4 weeks. We call the window period. So if somebody comes in wants to start PrEP, they have high-risk behavior, wants to start PrEP, during that window period, their test will be negative. They will meet all the criteria to start PrEP. The test they have on that day is negative, but in fact they do have HIV infection. The test is not positive. So if that person takes PrEP drug, which the PrEP drug is enough to prevent HIV but not to treat HIV, so the high risk for HIV resistance to come in that scenario. Another possibility is, as I said, there's resistant virus out there in the community. If somebody on PrEP is exposed to a virus that already has resistance, then the PrEP's not going to protect them in that scenario. That is extremely, extremely rare. So to date in the whole world, there's only been 6 cases of that identified. One case we identified here in Pattaya in Thailand. But out of hundreds of thousands of people taking PrEP, only 6 cases of that happening. So that's extremely rare. It's not something I would worry about on a regular basis. That other, what I mentioned before, somebody in that acute window period of HIV starting PrEP, it's not very common, but it's not that uncommon either. So when we looked at data at the Thai Red Cross and very similar data from other places, they come out with something about 1 out of 300 or 1 out of 350 people who start PrEP actually have acute HIV infection. So it's a small percent, less than 0.5%. But that's the scenario, as we start more and more people on PrEP, that's the one where we're going to see more often, and that may lead to resistance more often. But I think in the vast scheme of things, saying that there's already millions of people out there with resistant virus already, the number that are going to get resistance from PrEP is very, very small compared to that number who are going to get resistance from treatment of HIV.
So thank you very much for pointing that out in details. The last question would be that you mentioned that in order to prevent resistance, we may have to screen for acute HIV in a better way. Laboratory screening is one thing. You may or may not be able to do so depending on your resources. But clinical screening of acute HIV infection, could you please explain a bit more about that?
Yeah, so I'm actually not a big proponent of clinical screening because I think it's very difficult.
Yeah.
We know that the symptoms of acute HIV infection are very similar to a flu. So with the background of flu that's in the environment and the community being much bigger than acute HIV infection, any screening is much more likely to bring up flu cases than HIV. So I think rather than necessarily screening for acute infection, something we've discussed before and I've thought about is for people who may have an indication for PrEP, but we cannot rule out acute infection. So let's say that they've had an potential exposure to HIV within the last 1 month, and they could still be in that window period. So then I think the appropriate thing maybe is to put them on PEP. So PEP is 3 drugs, prevention, that works after exposure, but it turns out it's actually the same for treatment. So if we put them on PEP, we're actually on treatment at that point. And then bring them back in a month. We always bring people back in a month, whether it's PEP or PrEP, and then test their antibody again. Because giving them that 1 month that's enough time to get past the window period. And most people, not 100%, but it's going to be close to 100%, their antibody test will become positive within that extra month. So you give them a month of PEP, which is basically ART. If their antibody test becomes positive, you just continue 3-drug ART. If the antibody test is negative, then you switch them to PrEP at that time.
Thank you so much. Once again, a wealth of information, a wealth of knowledge you just shared with us, and we appreciate that. Dr. Donn Colby, Senior Clinical Research Physician at Search Thai Red Cross AIDS Research Center, discussing the perils of PrEP, STIs, resistance, as well as touching on screening there, wrapping things up. You'll be back with me tomorrow, and I'm delighted. I see that here on my agenda. And that's going to wrap up today's live streaming sessions. We also have to thank Dr. Nitya Panupak, also at Search, the Chief of Search at the Prevention Unit of the Thai Red Cross AIDS Research Center. Thank you to you. And we are going to say goodbye to our viewers joining us, live streaming here. Join us again tomorrow beginning 10:30 a.m. It's bye from us here at the 22nd Bangkok International Symposium on HIV medicine. สวัสดีค่ะ